This film is about people. When we do not feel well, when we are out of sorts, we often turn to over-the-counter drugs to help us resume our normal activities. If we have a headache, we may take an aspirin or a Tylenol or an Excedrin. If we have a cold, we seek relief from the stuffed-up feeling, the congestion, the coughing, and the sneezing. If we have a stomachache or heartburn, flatulence, we turn to drugs to eliminate the symptoms. Billions of dollars a year are spent on self-medication, drugs that help us feel normal and allow us to live normal lives.
One of the intriguing questions is which people become addicted. Why do people start to get dependent on drugs? Because lots of people use drugs. Most of us use drugs in Western society. Some form of mild stimulant, caffeine and coffee or tea to start the day when you need to be awake, alcohol at the end of the day, and several million Americans take a sleeping tablet at night to get a good night's sleep. And most people regard such drug use as normal.
We always think of the person who has problems with alcohol or drugs as the person who's on Skid Row falling down in the gutter. But this is not a valid perception. The person who has substance abuse problems or who has had substance abuse problems in the past is white, employed, and usually in the ages of 25 and 55. 73% of the people who have substance abuse problems are in the workplace. They are employed.
Drug addiction in this nation is the #1 problem, health problem in this nation. And we can begin with cigarettes and tobacco, move then to alcohol, and of course other illicit drugs. And I think it takes its toll on the American health population to the extent of billions of dollars a year, and it drives health care costs up, and our gross national product is affected by it.
The first time I got high on heroin, I felt, you know, it's almost hard to describe, but it was like my body was just waiting for this moment.
And it made everything nice, and I thought this was just such a wonderful way.
It's a feeling of enjoyment, of like you're on top of the world.
Very, very good. For the first time in my life, I felt very confident and something akin to happiness, because I was very unhappy at age 13.
I just noticed that I felt a sense of calm and peace with my surroundings and sort of normalcy that I'd never really experienced before in my life.
We know, looking at all the epidemiologic studies in this country and the world of this decade, but also of many previous decades, that approximately 1 in 4 to 1 in 8 who ever volitionally self-administer an illicit opiate become addicted. It's now estimated that there are 3 million persons in the U.S. who have purposely self-administered heroin. And yet the estimates of those who are addicted to heroin range from 500,000 to 1 million. That's a lot of people, and they come in all shapes and sizes, all ethnicities and genders, all economic groups, and all backgrounds. And in fact, very similar findings are now being made in many countries of the world in terms of exposure leading in some, but not all, to addiction. Now that itself is an extraordinarily powerful biologic clue that there may be an a priori predisposition or vulnerability in some, but not all.
I find in every single case, usually by the teenage years, they have a sense that they don't feel right, that their sense of well-being is not good, that they are dysphoric. And when they use that drug the first time, they will often say, I never felt better in my life. And what they mean is more normal, more calm, more settled, more serene. And then, of course, they continue to use it because they want to feel that way.
When we self-medicate using heroin, we fall into a trap. Heroin is a very short-acting drug. Once it is administered, we reach a level of euphoria. But very quickly, we slide through normal into withdrawal and feel terrible. So we crave more heroin to feel good again. As we use the drug, we need more each time to feel the same way. And each time we use heroin, the duration of feeling good shortens. So we must use it more often.
What people see then is the behavior. They don't see this biology. Yet this biology is constant from the top of the economic ladder to the poor person in an inner city ghetto. They still have the tolerance, the craving, the relapse. The condition is the same. It is just acted out in a different social and personal context.
Why in the world would anybody want to be addicted to any drug? Nobody wakes up in the morning and says, you know what, I'm going to become a heroin addict or an alcoholic. It is the most miserable, unhappy life. And the reason that they're not enjoying it any longer is because they have altered their brain physiology by the continual use of these substances so that they now feel dysphoric, unhappy, and miserable. And they would all love to find a way to stop using the substance because it's making them feel terrible, it's costing enormous amounts of money, and gradually it's destroying their whole life.
This heroin, which is illegal, expensive, leads an individual into a substandard lifestyle. What do I mean by that? He gets involved in criminality to be able to acquire the monies to buy the drugs, and he neglects every responsibility that a human being is responsible to have. He doesn't take care of himself, he doesn't take care of his family, he doesn't take care of anything, and his morals and his scruples change.
Was not a good thief. I didn't like jail cells, and you know, it was something that you know, I did a lot of borrowing and stealing, and my parents died early, and you know, the life insurance policies weren't a lot of money, but I still spent it, and you know, consequently, I had nothing.
But I could come out on my corner in my neighborhood at 9 and by 11 o'clock have $1,000. You know, so I leave 300 home and take the 700 back to New York, get $700 worth of heroin, which would translate to probably $4,000 or $5,000. I use half, so I end up with 2,500. Go up, spend 2,000, put the rest up. It was, you know, just back and forth.
I came to New York City at the age of 15 as a runaway, and I dealt drugs. I worked the streets, mostly as a thief. I boosted. I did many criminal activities. I spent a lot of my time in jail during the next 15 years.
I would say it basically ruined a large part of my life because when I had really gotten deep into drugs, everything fell apart. Like, I had concern for anybody else but myself and trying to get money to get high. I alienated my family. All relationships ceased to exist. I just had one relationship, and that was with the drugs.
Most persons could not sustain the life of an addict where he has to spend $100, $150, or $200 a day. Not an easy chore, particularly when he starts off the day with zero finances. So he goes through this process. It becomes a pattern of behavior. We also have to understand that addiction per se is not just an addiction. It's a social disorder, it's a psychological disorder, and it's a pharmacological disorder.
The net effect in most situations will be that people will, if they avoid arrest, will pick up a variety of diseases and will treat them for those diseases, whether it's AIDS or some other bacterial infection, but we'll pay the cost for that. And the other alternative is that they get arrested and they be put in prison. The net effect of that is that we pay for the cost of the prison, which is several-fold higher depending on what kind of jail or prison you're in, than providing treatment with methadone or the community. And that during the period of incarceration, people aren't functioning, nor are they learning how to function in a law-abiding, productive way. So you have a revolving door, and when people are inside your institutions, you're paying a lot, and when they leave, generally they relapse to predatory behavior or other illicit behaviors, and it's simply far costlier. So these are the options. If you get people to accept treatment voluntarily, it's a bargain for society.
They may approach treatment because there's a level of chaos in their life or a level of desperation or some coercion out there, but they're not really convinced that they want to eliminate drugs. What they are sure of is that they can't go on like this.
Either they are forced in because they can no longer afford the amount of drugs that takes care of their tolerance to the drug, and so they don't feel the high anymore, and they can't rob enough to buy enough to get the amount that's necessary, so they come into drug treatment.
Honestly, the very first time I went into treatment, I was kicked out of my house. I had no money, no food, nowhere to go.
All day long, every second of my life, I thought about where I was going to get the next hit from. And at one point, I kept the syringe in my neck, clogged it with from a cigarette butt, wrapped a towel around my neck. So then all I had to do is fix up the dope, take the cotton out, push it into my neck, and inject.
I ended up homeless. I ended up a criminal. I ended up alienating my family and my friends completely, etc. I never wanted to be an addict. I never accepted the idea that I was going to be an addict for the rest of my life, etc. I wanted to stop.
My life just went downhill. I started becoming everything I was trying to work against. I started getting in trouble with the law, and I found myself back and forth to Rikers Island. But every time I would get out, I would go right back to the same thing.
Treatment is about healing. In the early 1960s, Dr. Vincent Dole, a professor and physician at Rockefeller University, was appalled by the devastation caused by heroin addiction in New York City.
It was clear that there's something special about addicts because many people are exposed to narcotic drugs in the course of medical practice, and only a minority of them become addicted. And the question is, why is the addict different from the others? And it did not seem satisfactory to say they were simply morally weak people. The one person I found that made good sense to me in the medical way was Marie Ponder. The title of the book, The Drug Addict as a Patient. This totally refocused the field because the drug addict is seen as a pariah or as a problem or as a deviant or whatever else. But here, she brought the matter right to the middle. The drug addict is a patient who needs medical care, medical understanding.
At the time, the Federal Bureau of Narcotics was prosecuting physicians who attempted to treat addicted people with medication. Addiction was considered a police problem, and addicts were considered criminals. Dr. Dole utilized the resources of Rockefeller University, including the influence of the legal staff and the president of the university, to overcome the legal issues that hindered his research.
And our first job was to simply make a survey of different medicines to see what, if anything, would have an impact on the addiction of bona fide, true, hardcore addicts. The addiction is not a toxicity. Addiction, if anything, has to do with a deficiency. In my own theory, the heavy use of narcotics tends to deplete certain neurotransmitters in the brain, and methadone is capable of taking these damaged people and giving them a replacement medicine in the brain that it permits it to function in a more normal way.
To better understand how methadone actually affects brain function, it is useful to look at the biology of heroin addiction. Heroin's ability to create intense activity in the brain's reward center is what accounts for the powerful, pleasurable sensation referred to by addicts as a rush. Once heroin enters the brain, it binds to specific opiate receptors, activating them all at once, creating a flurry of intense electrical firing. Methadone occupies the same receptors as heroin, and by doing so, eliminates the craving that accompanies withdrawal.
What it does do is come on in a slow fashion, fill the opiate receptors. The patient feels no euphoria, no physical impairment whatsoever, yet has no physical cravings for any opiates, and mental cravings are diminished significantly.
Heroin is a fast-acting drug of short duration that causes extreme highs, then sudden drop-off to withdrawal misery. Methadone is a slow-acting medication, taken by mouth with a duration of at least 24 hours. Taken once a day, methadone balances brain chemistry and allows us to stay in the normal zone.
In the case of methadone treatment, there is no other medication, there is no form of treatment. Not residential drug-free, not outpatient drug-free, not acupuncture, not yoga, all of which, each of which has its own role as contributing to the types of treatments that are available to people. But methadone is absolutely without parallel in terms of the likelihood that it will benefit the patient, its acceptability to the heroin addict population, and its proven safety and efficacy.
In 1967, and I had been hearing about and reading about methadone maintenance, but was very skeptical about it. And in sheer desperation with one of my patients that had relapsed repeatedly, I said, well, I'm going to try one more thing before I give up. And I was put him on a moderate dose of methadone. And what I witnessed was an instant normalization, a stabilization in life. And he described it as if he had never felt that way, even before drugs. He felt that somehow this medication supplied something that had been missing.
I see people coming daily. I see them improving in their general health because they're now in a proper routine. They're not having to engage in a heavy program of crime. I see they're having fewer appearances in court. I see them able to look after their children. I see them being able to get jobs. I see their sociability so much improved.
When they come into methadone treatment, we have an opportunity to stabilize the pharmacotherapy. We see them on a daily basis. We provide a full range of comprehensive services. We're able to provide the linkage to health care, which they may never have been able to get before.
Methadone maintenance is a very reliable, is a very viable that allow you to keep patients in treatment for a long time. And the condition of patients, of course, are stable.
What we found from working with these stable patients, and mind you, they were only stable for 6 months, what we found from working with them was that once someone had figured out how to become stable in a methadone program, with little support from the clinic, they could maintain their stability. If they had figured out what it took for them to be sober, what it took for them to extract themselves from drug-using lifestyle, they were able to maintain that.
Methadone itself, for some people, is like a lifesaver. They really couldn't function, work, exist without it. Then comes the crucial question. What can that person do with his or her life now that that part of the brain has been stabilized? Do they have a job that they can perform? Do they have talents they can pursue? Are they going to go to school and get a degree or some vocational training?
It's not one size fits all. It's not a recipe. But I believe there are some people who can become drug-free without methadone maintenance. But sadly, it's probably only 10 or 15%. The relapse rate of opioid addiction is at least 85% once you're truly a hardcore addict.
Methadone maintenance helped me considerably, simply because the chronicity of my addiction would have caused me to take my gun and go and get money. I would have went in a bank, I would have went in somebody's house, I would have stuck somebody up at gunpoint, I would have hurt someone to get money for my addiction. With the methadone, I did not have to commit crime, and that was a big piece for me.
I've been on methadone for 25 years. It helps me function, it helps me work, and it's right for me. As someone said to me, you know how you look at it? If you have diabetes, you take your medicine every day. And this, I go in, it's 5 minutes out of my life if I want it to be. Or it's maybe an hour or two. I go to groups, you know, there. I have a wonderful counselor, Jennifer. Christmas is coming, we have Christmas parties, you know. One year I didn't have anything for Thanksgiving, and I walked in the program, it even makes me cry, and there was a big box of food for me. And usually it's the people that have children that they do for. They help me so much over there.
By going to these groups, I started listening, and sometimes you would think that, you know, I can say, but you'll find yourself speaking as time goes by. And I ended up going to a vocational group, and they were giving a test for college, an entrance examination for college. And like the lady said, you know, I have nothing to lose. If I fail the entrance exam, I'm no different off than if I didn't take the test. So I took the test and I passed.
I could not have made it with a therapeutic community. I was not able to do that kind. I don't anything against that form of treatment. There's a lot of wonderful people who have changed their lives using therapeutic communities. I could not have. I needed that really gentle introduction to having a caring clinic, to spend a couple years getting used to the idea of not using drugs every day. That was so essential to my recovery that people like me would fall by the wayside. And all my successes just couldn't have happened without methadone.
It's not a great drug, it's a wonder drug if you have this disease. It would be as if you had the diabetes and all of a sudden somebody comes up with the insulin. Well, if you have diabetes, that's a life-saving wonder drug. And if you have this disease of opiate addiction vulnerability, this drug makes you feel normal and function normally.
Based on a study that was done by Dr. Dole and colleagues in 1991 using New York State data, that approximately $50,000 is spent for the untreated heroin user, and about $35,000 is spent if that individual is incarcerated, and that $5,000 is spent on average for the person being in methadone maintenance treatment. More than 800,000 people who use heroin who are not in treatment, and you compare that to the 180,000 people who are in methadone treatment, and you look at the reality of younger people becoming addicted to heroin at ever younger ages. 2.5% of 8th grade students using heroin is a chilling piece of information.
Addiction is a disease, and methadone is a medication that treats the disease. But in the United States of America, we don't have a disease model. We have a criminal justice model about addiction. We've always treated addicts as criminals. We have always had a focus on addiction as a crime. We've always looked to incarcerate people who use drugs. The idea that this is a disease and doctors should treat it with medicine is foreign to most Americans.
We're not trained in medical school about addiction. There is no postgraduate training in the curriculum about addiction. Many of the individuals who train in New York now run into addictive behavior in hospitals when they're in their postgraduate training, and so they have to learn something about it. But what they learn is fairly negative, and that is that we don't want to treat these people because of the way they look or the way they are, and what has been depicted about them in the media.
Methadone treatment has not been well accepted
in the medical community in general. I believe primarily because of a lack of information and the fact that methadone treatment has been isolated from the mainstream of healthcare in America basically since its inception. And the general medical community needs to be one of our primary partners in increasing access to methadone services, to improving the quality of care in addiction services in general.
And that's the catch in methadone, that the people who are using it as a medication, who are doing well, are invisible. And so that people think they don't know anybody who's on methadone treatment, but they actually do. Because my patients are all over the place. Name a profession, name an occupation, I've got somebody who does it. My patients have an average family income of about $70,000 a year. Over half of them are college or graduate school graduates, and all that schoolwork was done after they got on methadone.
I basically feel that the answer to all of the quote problems associated with methadone treatment, the irrational expectations, the constraints on expansion, the regulatory costs of providing treatment and so on, all of those problems can be eliminated instantaneously if one simply said we will apply to methadone treatment of narcotic addiction the standard accepted ways we deal with all problems with any medication for any illness.
This is just not bad behavior, that this is a chronic brain disease, has association with a lot of physical problems, and that treating of this disease will bring about a considerable savings of lives and of money. And, you know, it could, on the economic basis and on a healthcare basis, and that it could do very well if we expanded treatment programs, made them available in every community, and talk about the good of those programs.
I felt like a new person yet again. I mean, a different kind of new person, but I felt, I felt like I'd been given a chance, and like I dodged a bullet, like I'd really gone through an incredibly dangerous, stupid period of time, and that I was incredibly fortunate to be alive, that I was incredibly fortunate to be free. And I clearly saw that without having had methadone available to me for the preceding 6 years, I would not have been there. I would have been in a grave, or I would have been in a cell, or I would have been infected and waiting to die.
They're happy with me, yeah. Both my parents are very sick, especially my dad. And not only to be allowed in the house to help out, but I can go into their, you know, Mom says Genevieve's is coming with our prescriptions. I want to give them go get my purse. You know, you don't tell somebody that's been on drugs this long. I can go in a closet and get her purse. I can, Daddy needs his Inderal for his blood pressure. You know, I go and I couldn't even go near the pills even if they were aspirins. I'm trusted now.
Oh, my family, they're very, very happy. Very happy. They couldn't understand in the beginning why I went to a life of drugs anyway. Because I come from a family that nobody ever used drugs. Everybody went to school. They were all professional, doctors, nurses, and stuff like that. So they couldn't understand it. I couldn't understand it myself, to be honest with you.
I began to really think about my future. And I tried to get a job, but I was a high school dropout with no work experience, and it was almost impossible to find any kind of employment. So I got this notion that maybe I could go to college. I knew I was bright because I had always read a lot and I had done really well in my early school years. And I heard about this program at Columbia University. I ended up graduating magna cum laude with honors in psychology. I received a few academic prizes that had money attached to them. I was elected to Phi Beta Kappa. I did well. But as I said, it didn't happen overnight. I didn't walk in the methadone program and within weeks end up at Columbia University. It was a passage of a number of years. But being in a place that cared about me, given a medication that made me feel normal, allowed me to begin to care for myself. And it changed my life.
move then to alcohol and, of course, other illicit drugs. And I think it takes its toll on the American health population to the extent of billions of dollars a year, and it drives health care costs up, and our gross national product is affected by it.
The first time I got high on heroin, I felt, you know, it's almost hard to describe, but it was like my body was just waiting for this moment.
And it made everything nice, and I thought this was just such a wonderful way.
It's a feeling of enjoyment, of like you're on top of the world.
Very, very good. For the first time in my life, I felt very confident and something akin to happiness.
This film is about people. When we do not feel well, when we are out of sorts, we often turn to over-the-counter drugs to help us resume our normal activities. If we have a headache, we may take an aspirin or a Tylenol or an Excedrin. If we have a cold, we seek relief from the stuffed-up feeling, the congestion, the coughing, and the sneezing. If we have a stomachache or heartburn, flatulence, we turn to drugs to eliminate the symptoms. Billions of dollars a year are spent on self-medication, drugs that help us feel normal and allow us to live normal lives.
One of the intriguing questions is which people become addicted? Why do people start to get dependent on drugs? Because lots of people use drugs. Most of us use drugs in Western society. Some form of mild stimulant, caffeine and tea, coffee or tea to start the day when you need to be awake. Alcohol at the end of the day. And several million Americans take a sleeping tablet at night to get a good night's sleep. And most people regard such drug use as normal.
We always think of the person who has problems with alcohol or drugs as the person who's on Skid Row falling down in the gutter. But this is not a valid perception. The person who has substance abuse problems or who has had substance abuse problems in the past is white, employed, and usually in the ages of 25 and 55. 73% of the people who have substance abuse problems are in the workplace. They are employed.
Drug addiction in this nation is the #1 problem, health problem in this nation. And we can begin with cigarettes and tobacco.
Because I was very unhappy at age 13.
I just noticed that I felt a sense of calm and peace with my surroundings and sort of normalcy that I'd never really experienced before in my life.
We know, looking at all the epidemiologic studies in this country and the world of this decade, but also of many previous decades, that approximately 1 in 4 to 1 in 8 who ever volitionally self-administer an illicit opiate become addicted. It's now estimated that there are 3 million persons in U.S. who have purposely self-administered heroin. And yet the estimates of those who are addicted to heroin range from 500,000 to 1 million. That's a lot of people, and they come in all shapes and sizes, all ethnicities and genders, all economic groups, and all backgrounds.